This patient initiated bendamustine and obinutuzumab with planned obinutuzumab maintenance based on the Catalan study. Unfortunately, within 11 months, had evidence of disease progression based on imaging, which suggested, in addition to the known sites of lymphoma, he had new pathologic adenopathy, including bulky mass in the mesentery. How would we approach a patient in regards to third-line treatment options for relapsed refractory follicular lymphoma? Idelalisib is FDA approved in this setting and would, again, this patient would have met the eligibility criteria for the prospective study that enrolled, meaning he's failed 2 lines of chemotherapy and CD20 antibody. Idelalisib is a targeted agent that targets PI3 kinase delta, and the phase 2 study demonstrated very high overall response rate that appeared to be quite durable. There are side effects associated with idelalisib that are unique in regards to what is traditionally seen with chemotherapy, including transaminitis, pneumonitis, colitis, and risk of infection. The timing of the onset of these adverse events is somewhat different than what we traditionally see with chemotherapy, meaning we have patients who will be doing well and on treatment for many weeks to months and all of a sudden have significant side effects that occur. In general, the side effects of idelalisib are quite favorable, meaning few patients will have severe or significant side effects. However, given the side effect profile is unique from traditional chemotherapy, it's important to ensure that these side effects are identified in a timely fashion, meaning addressed early before side effects can progress to the point of severity that will lead to prolonged drug hold or prolonged treatment of these side effects. For instance, if you have a patient calling with diarrhea beyond their 6th month of therapy and they're having more than 5 bowel movements a day, the first advice is to hold drug and investigate for evidence of colitis or even other etiologies of diarrhea. So it's also important to educate office staff as they will be fielding those first calls. And oftentimes patients will call with diarrhea, and for someone who's been on therapy for 6 months and generally responding, colitis may not be the first side effect that the triage nurse is considering. So I think it's important not only to educate the treating team, but also the team that may be fielding those calls, as well as the patient in regards to the side effects that you may consider more serious. In addition, infection is something that we've learned is important to monitor for throughout the course of their therapy. Neutropenia has been associated with idelalisib, again, which is not traditionally been thought to be associated with targeted therapy, but as we gain more experience with these agents, we know that cytopenias can also be a problem. So monitoring for neutropenia, which can also put patients at risk for infection, is important and is currently advised to be done approximately every 2 weeks during the first 6 months of therapy. Rash can also be seen with idelalisib. So again, most rash is mild and easily managed. Being mindful of more severe eruptions is also important to educate patients and staff who might be managing these patients. But again, in general, the side effect profile is very manageable with idelalisib, and it's offered therapy for patients who have traditionally failed chemotherapy, have gone on to receive this agent and respond quite well. It is an agent that's currently approved for someone who's had 2 prior lines of therapy for follicular lymphoma. So I think it is a reasonable option to consider for this patient. In regards to emerging therapies, there are ongoing prospective studies looking at additional agents such as immune modulators or other targeted agents such as enzymes within the B-cell receptor signaling pathway. Those are not as far along as idelalisib, meaning they're not currently FDA approved, and we're eagerly awaiting some of those studies to read out. Approach to patients who've relapsed in follicular lymphoma is just as heterogeneous as the disease, meaning you have to consider what their prior therapies were and the sequence of those therapies when you're deciding on their next therapy. I've oftentimes treated patients with CD20 monoclonal antibody if that's appropriate, meaning someone who's of low tumor burden but in need of therapy. I've also alternated chemotherapy based on what their prior chemotherapy is. I think specifically for this patient who's having a short remission duration following chemotherapy, that a third-line chemotherapy-based approach is less exciting. I would strongly consider a clinical trial if you cannot or are not in agreement with idelalisib for this patient population, and given his age and likely limited comorbidities, consideration of an allogeneic stem cell transplant should also be considered. My approach to patients who are looking at their third-line approach for relapsed refractory follicular lymphoma takes into account their underlying patient characteristics such as their age, their comorbidities. I also consider their disease characteristics. I do consider the Guelph criteria even in this setting because, as I mentioned, there are oftentimes patients who are of low tumor burden but in need of therapy where less intensive therapies may be appropriate. I will strongly consider a clinical trial given the emerging targeted and immune therapy approaches which appear to be promising in this disease, which are often restricted to use on a clinical trial. And as I mentioned, given a young patient with limited comorbidities, consideration of an allogeneic stem cell transplant beyond their second remission is absolutely appropriate to consider because it may be associated with a chance for cure.